Well, hello, Lowell, and welcome to the 7th episode of Recovery Matters. And we've had some fascinating talks together, and we're so happy to have you here. And today we have a very interesting show. You're going to love it, so definitely stay tuned. Do not change that channel. We're doing Caring Together, integrating addiction care. As you know, Lowell House is an addiction treatment and recovery center. And we really focus on, I think, what's the #1 health problem in Lowell these days, and that is substance use addiction. And our treatment agencies work with a number of other agencies. So I want to, just before we do that, just want to tell you about a really nice thing. I'm sure Brian will put this on so you can see it a little bit better. But we are having our recovery breakfast. And recovery, as you know, is all about hope. And our keynote speaker will be Dan Ray. We do this every year. First year we had the governor. Dan is fascinating. He gives a great speech. But after that, Karen Anderson will introduce Michael Sprinsky. And Michael Sprinsky was the individual who went into recovery and stayed in recovery for 2.5 years to be the key witness against, and I think it's Michael Callahan, but the baby doe killer, the convicted baby doe killer. You all remember Bellabond, and he was convicted last June, I believe, of second-degree murder. So, and he stayed in recovery all that time to do that. So it's going to be an exciting program. You hope you can join us September 19th at 7:30 a.m. at the Inn and Conference Center. So we have an essential question this morning to really talk about. We have so many wonderful agencies in Lowell, and we all do great work, but we do a lot of duplication. We have a lot of people doing different services that never get connected, and probably the complaint I hear the most is, what do I do? How do I get this service? Where do I go? How do I find it? And it may be out there, but if you can't find it, it's no good to anyone. So as we know, recovery isn't just withdrawing from a substance, but it's a change of lifestyle for an entire lifetime, the whole disease of addiction. So why don't we coordinate our services, and why don't we play well together as agencies and as professionals? So I'm going to introduce my panel this morning. We have a great panel. To my right is Dr. Mark Albanese, and Mark is he's an addiction psychiatrist. He is a director of adult outpatient psychiatry at Cambridge Health Alliance, and he is also our medical director and has been with us, 20 years now?
Something like that.
At least, because you're only 25, so you started really
just
early.
out of high school.
Just out of high school. That's right. That's right. And to his right is Susan West Levine, one of our great partners and one of our official partners now. We maybe talk a little bit about that. But she is the CEO of the Lowell Community Health Center. Right down the street, and where we'll soon be moving in about a year. We'll be over and joining you over there. So that's exciting, and welcome.
Neighbors and partners.
Yes. That's right, because we will, I guess, cohabitate? No. Is that the right word? Whatever. Anyway.
Let's not go there.
That doesn't sound right. No, that doesn't sound right. Erase that one. Anyway, to my left is Carrie Detremont, and Carrie Detremont is the executive director of the Lowell Community Health Alliance. And Carrie does a lot of bringing people together and funding of projects. So very exciting. So let me ask you all the question, and maybe we'll get with you, Sue, about this, of why don't we play well together? What is it over the years? Because I've been doing this many years. We've never played well together.
Well, I think the incentives in healthcare foster operating in silos. And essentially, I believe at its core, it is the reimbursement system at play that encourages paying for that particular visit, that particular encounter, and does not allow sufficient funding to support care coordination or transitions of care, or spending the time making sure that the behavioral health provider has some time with the medical provider to manage the person's overall care plan. And the financial system, essentially, the insurance system, is really built on the framework of paying for that particular service in that particular moment.
Okay, and that's been a problem with our entire healthcare system.
Absolutely, yeah.
As a physician, Mark, how do you view that?
Yeah, I agree with you, Sue. I think so, but just to step back for a second, because we've already established I've been doing this for a long time, and
since high school.
Yeah, since high school. I remember the days when we really didn't play well together. And again, I don't want to make it all sound like, we've fixed the system, and I every week hear from people who are trying to navigate the system. So I get it that there's still problems. But, there was a time where, if you were a mental health agency, you didn't even know that addictions agencies existed, let alone talk to them. So, we've certainly come a long way. I think that you talked about the reimbursement aspect of it. I'm a clinician, so I think about what is it that clinically gets in the way, and I think that people who do the work kind of cling to ideologies that don't really work in the 21st century. So that the notion that when you're treating addiction, for example, you're treating any number of associated issues, mental health issues, psychosocial issues like homelessness, underemployment, and I think the system is still trying to catch up with the fact that a system that really was responding to different pieces, responding to different problems individually. It's kind of like touching part of the elephant, right? And you realize that, that story about 10 different people touching the elephant, and they think it's 10 different things.
I remember that one, yeah.
But in any case, I think so. The system has to change so that everybody's working together to appreciate the full breadth of the problem. So if somebody walks through the addictions door, that agency is as capable of identifying all the other problems that somebody has. Again, like homelessness, like mental health issues, that kind of thing. And I think we've gotten better at that, but I still think that there's some clinging to this kind of like, well, this is how I see it. Well, maybe how you see it doesn't really work in the 21st century.
Yeah. Well, when I first came to Lowell House, one of the things I heard from people is that this is the best kept secret in Lowell. And why would we want to have a best kept secret in Lowell? And so many agencies we really don't know about. We don't know what they do or how they do. So Carrie, what do you think about that? And what can we do about it?
Well, I think one of our major goals at the Greater Lowell Health Alliance is bringing all these different players to the table. We strive to get people to work together just through the sheer nature of a coalition and an alliance, getting people to sit at the same table and discuss some of these issues, but have that level playing field and discussion and really kind of work on some of these issues. Yes, we've got a long way to go, but I think we've made some great strides in even our grant application process through the Greater Lowell Health Alliance is really structured in a way that the community is designing the community health improvement plan, and we're basing our funding based on those 50 different organizations have come up with this plan, and now we're funding in a way that works to achieve those goals that have been set by the community and by these agencies. And this was a development of over 50 different agencies this year that we've been working on. So I think it's, this is the first year that we've done this community health improvement plan. So we've, got a long way to go, but I think it's a great step if we can, have everybody focusing on a few goals and a few, areas of focus, then we hope to achieve some measurable change, you would hope, and in that structure, we also really push to collaboration and agencies working together, and the grants are scored higher just by showing that they are working together and sharing those resources. Our community is so rich in resources, like you said, best kept secret. We're so rich in resources, it's just getting, taking the time out of your silo to know what resources are out there and really take advantage of each other's resources and what we do best, each as an agency.
And we're still very competitive.
And we're competitive.
We're competitive. And we still, when a grant comes out...
Not with one another.
Well, even occasionally we can be. And I think it's hard getting over that piece because we see it come out, we say, okay, we want that program, we want those dollars, and let's fight for it. And hopefully no one will write a better proposal than anyone else rather than go out necessarily, and we do more of this now, I agree with Dr. Albanese. We do more of it now. So what are the consequences of what we do?
I just want to add to that last point, though. Funding agencies are changing how they're putting out their grant proposals. And so at the core, they're funding proposals that are collaborative in nature. And that's
right.
taking one of those incentives out of the system, the incentive or the disincentive to collaborate. And so
Right.
just like the Greater Lowell Health Alliance is promoting collaborative proposals, so are
Right.
state agencies and federal agencies. And so I think that's when we're going to see, so we need the insurance market incentives to change, and then we need the grant funding climate to change to foster collaborative efforts. And that's what we're seeing now. So it's a really awesome time to be in healthcare.
It is. And I think, from our perspective, it's been fairly slow because we've been
Yeah.
doing this a long time. And we see the consequences. What are some of the consequences of a disjointed system for the people we serve, especially the people with substance use disorder?
Right. No, I think, outcomes aren't as good for people. If somebody comes in with opioid use disorder, as so many people do
Yeah.
now, and they've experienced a lot of trauma in their lives, the likelihood that they're going to go into recovery is far, far greater if at the same time as you address the opioid use disorder,
And sustain recovery.
right, you also address, the trauma and the resultant PTSD. And again, just the on the positive side, 10 or 20 years ago, the notion that you might be talking about trauma or PTSD at an addictions program was just so, it didn't happen.
Right.
People didn't believe in that, and so we've come a long way, but it does, the system's not totally set up to be coordinated, and we're getting there, as you point out. But you ask what the consequences are. People just don't do as well. So whether it's somebody who comes in for mental health treatment who has a co-occurring alcohol disorder, or somebody comes in for addictions treatment has a co-occurring mental health disorder, unless you're able to coordinate care of both of those things at the same time, people aren't gonna get better from whatever disorder that they came to treatment for.
Right. So the outcomes won't be there. We're not going to have cost savings.
Right.
Okay?
And then the issue that I'm primarily concerned about is on the primary care side.
Right.
If you have a fragmented system, you have potentially a group of primary care providers who may not be as comfortable treating individuals with a substance use disorder or a mental health impairment because they lack the support systems. And so the more we can get that multidisciplinary team together, then you're going to create more access on the primary care side to early identify those individuals in need.
So how does this tied in, coordinated system look? What's our vision for the future of the system? And then I think we'll talk about a system that's actually happening that you and I are part of right now, which I think is very interesting. But what do we do? Because I'm a parent out there thinking, yeah, you know what? My son or daughter has a treatment person, but they need some health care. They have health care issues. Before that, they were drug shopping, so they were going from doc to doc and trying to find medication. So what does this coordinated system look like, and how do we tie it together?
Well, I'll take a first
sure,
stab.
Sue, please.
I mean, I think there's many ways in which it can play out. But again, kind of picking off on the point I was making on the primary care side, wherever an individual, whatever door an individual walks through, and there's been an identified behavioral health, mental health, or substance use disorder issue presented, that provider has to have the tools in order to support the individual in their care plan. And overlay with that a care coordinator who's really, and you can call that care coordinator many different things, but someone who is really going to look at the entire care plan and coordinate across the providers, watch out for these transitions of care, and provide the enabling supports, which go beyond just traditional medicine. It could be, as you were talking about earlier, it could be housing or employment opportunities. And so it's really right when an individual is identified, and then connecting them with a role such as a care coordinator that can really guide them through the process. And that's what's not typically been funded.
Right, right. So, it's an issue and a discussion with my staff frequently about saying, well, we're a treatment agency, but a treatment and recovery really means healthy living. It means allied health services. It means good medical services. So from a funder's point of view, you're starting to do more of that. How can you take it to the next step? What kinds of ideas have you talked about, especially in the strategic plan you've done?
Yeah, with the strategic plan and the CHIP, we call it Community Health Improvement Planning, we follow the needs assessment that's done every 3 years. So we have those areas of health that have been identified, and so what the community has really taken is some ways of pulling in those social determinants of health and how to streamline that through each of these areas. So mental health is a top issue, substance use and prevention is a huge issue, and how can we try to make sure that we're carrying through, the healthy, active living parts, intertwining it, because we even said as we were discussing this, we're segmenting people into groups to talk about all these different things. We're furthering the silos because we're continuing to have people, in groups talking about mental health. So one of the ways we did it is, bringing all these community agencies together, but we kind of flip-flopped it and had everybody sit where they felt most comfortable in the work that they do. But then we turned it around and we had we had healthy eating now move to the mental health table, and we continued that process, and it was really interesting.
It was a great process,
and it got us really thinking about, okay, so mental health and substance abuse we're constantly separating on our plan. Those really need to be intertwined, and those identify some areas where we can work together. So it's a step, in the right direction, and then one of the ways, some of the areas that were identified, like diabetes and hypertension. Instead of focusing on them as a health priority, we've decided, we really need to focus on healthy eating and food access and physical activity, and those are the things that really we need to focus on and come up with some strategies for.
And that's, I just want to go back to 2 points. One is, you've alluded a lot to medical or physical well-being. We've talked about mental health and addictions and social determinants. But, getting back to your question, Bill, about, what's the result of this kind of, disjointed system, there are medical outcomes are worse, right? So people, if you're not adequately treating mental health and addictive disorders, people can't get a grasp on a healthy lifestyle.
Right.
So, in the end, those outcomes are better. I mean, people take better care of their diabetes. They're now in recovery, so they can address hepatitis C. So you end up with a healthier group of people. That was one point I wanted to make. The other thing I wanted to say, when you ask, what does this system look like? I'd say it's a system that is open and willing to listen, not judgy, and not setting up these false ideological obstacles that I alluded to. Give one example of that. I do a lot of medication-assisted treatment, both buprenorphine and methadone. And I'm not saying that that's the way for everybody with an opioid use disorder, but I don't think there's a place anymore in healthcare for, this belief that, well, I don't believe in that. I'm sorry, it's not about what you believe, it's about what works for
It's
a
really
lot of
about
people.
practically keeping people in recovery.
Right, absolutely.
So, and that's a really good point. So, in basically our last 3 minutes here, we're almost out of time. It goes quickly. The federal government is beginning to do some oversight into this process and forcing us and really putting the physician, especially the primary care doctor, in the middle of this process. So we just got awarded our behavioral health partnership. I think we can announce that, right?
Yes, I think
And that's
we were
us.
selected, pending contract
we were
negotiations.
selected, right? And that's us, Lowell Community, Lowell House,
Lowell House,
Community Health
Lowell
Center. Too many
Community Health
Lowells in
Center.
here.
I know.
And the Mental Health Center of Greater Lowell.
Yes,
Greater
absolutely.
Health Center Alliance. So anyway, Sue, talk a little bit about this whole now, we got a whole new alphabet of stuff. We have the ACOs.
Okay,
and
we
the
need another half
MCOs.
hour.
I know. But in 2 minutes, let's
minutes.
talk about why this is so important and what the government has done to sort of push us together and save money and have better outcomes.
So at the state level, the state is in a major delivery system reform effort. And they are creating accountable care organizations with Alphabet One, ACOs, and that does exactly what we've been talking about in these last 24 minutes, and that is to put the incentives in place for providers to better coordinate and integrate care to take care of the whole person. And in talking about those insurance incentives that have been disincentives, this now reimburses groups of providers on how well they do in overall health outcomes. It's not that fee-for-service world. So that's great. That's a shift in the right direction. The contract that we were just awarded is essentially a subcomponent of this accountable care organization model, where the state wants groupings of behavioral health providers across the state to become certified behavioral health providers that the state and or ACOs can refer individuals with mental health, behavioral health, or substance use disorders. And so we had to apply to become certified behavioral health providers, and the state really, again, and this is about funders changing the incentives, they wanted groups of providers to form strategic partnerships in applying to the state. So right here in Lowell, the Lowell House and the Lowell Mental Health Association of Greater Lowell and Lowell Community Health Center, we each provide pieces and components of the behavioral health spectrum, and we got together in partnership, submitted our application, and the press release should be out today.
Very exciting
It's
because
very
they're
exciting.
requiring that the physicians be involved in the
Yep.
plans and that we do good treatment plans. And like
Yep.
you've done with your funding, the funding essentially drives what we do.
All right.
So as funders pay
Utilize it.
attention to this and help us move together, it'll be far less confusing for families, because I know this is a big issue for families
Right.
of how we get care. So stay tuned, because we're hoping a year or 18 months from now, we'll be looking at a different system. So I wanted to thank you all for this. This has been terrific. And we just touched a little bit, but I think on some very important issues. Upcoming, we have a great film we've done, and this is about another philosophy of ours, which is families are the essential part of recovery. So it's a film about families. You'll see some people that are in recovery, and you'll get some ideas of what they've gone through, who they are and where they are now, and the bright future they're facing. So enjoy the film and give us some feedback. I'm Bill Garr, again from Lowell House Addiction Treatment and Recovery. Thank you, guests, and we'll see you
Happy
at
to be here.
another month on episode 8.
Thank you. Thank you.
Opioids affect so many people. They affect family members, they affect loved ones, they affect our colleagues.
How can we not care about this epidemic that has taken so much from so many within our own community? As we all know, treatment resources are very, very scarce.
The community of Lowell and nationally are in the midst of a major opioid crisis. This is something in the past 10 years that has grown exponentially.
Can I do it now? Can I do it all by myself?
It goes from being something that's fun and something that makes you feel good or feel better to something that makes you want to kill yourself every single time you use. You know, like when you cross over that line, you have no idea you just crossed the line. My addiction got to a point where I was definitely a danger to myself and to society. And my family, thank God, got a judge to agree with them that I was a danger to myself, and the judge sectioned me. Hold the railing.
I knew that the person experiencing it was powerless over it, and that I was powerless over it. It struck at the family. I feel like it struck at the core of our family. It got to a point where the possibility of losing her was very, very real and very constant.
There was a spot open at the Lowell House, and I went into the program there. You know, I was so tired and I was so broken and I was so empty. I thought a nice little break, just let my body relax for a little while, and then I'll figure out how to do it, because I can do it on my own. That's what I thought. Addiction is a disease, and a lot of times it wasn't one event that started it all. I'm married, I have an incredible husband. I just finished a nursing program. I just graduated nursing school, and I'm waiting to take my NCLEX. In October, on October 15th this year, I will celebrate 11 years clean, and it's incredible. I have recovered every single thing that I gave away to this disease. I can't imagine that I would even be alive if it wasn't for, the Lowell House and if I wasn't clean today.
Well, I kept telling myself, oh, I'll stop, and once I finally stop, I'll be good. I just have to get myself to stop for the first time. My tolerance kept going up and up. The amount went up and up. My money got less and less because I was just spending everything I had on them. I told my sister at the pizza place, hey, I got to go home and talk to mom and dad because there's something I got to change.
To find out that he was doing drugs was a complete shock to me and his mother. We never saw that coming. The program at Lowell House invites and is very accommodating for family participation. There is a stigma, and that's why a lot of families don't talk about it. They gotta remember that that's one of their own. We are in this together. We are going to deal with this as a family as we are doing it right now.
My biggest motivation and tool is just not wanting to let people down.
Something bad was happening, but something good is coming out of it, and that's the part that I hold on to.
Half pepper onion, half pepper, half mushroom.
My parents never gave up on me. They are the ones that saved my life. I think having a spot available when somebody is ready to get help is huge.